Treating my sleep apnea has renewed my appetite for life. What matters to me now is giving my family a little treat.
All right, it's time for another show, and that means pre-cals. What's going on today, gentlemen?
Jerry, we have Dr. Mohammed Usama, who is triple board certified sleep and obesity physician and one of the leading voices in sleep medicine, based in the greater Seattle area. He also serves as an adjunct assistant professor of medicine at Still University School of Medicine. His clinical and research interests center on the intersection of obstructive sleep apnea, obesity, and metabolic health, with a particular focus on GLP-1 therapies like tirzepatide that can shape outcomes for patients with OSA, obesity, and cardiometabolic disease. Well, we've got somebody with a lot of background coming at us today. It's going to be exciting, especially to talk about GLP-1s. I know that's been a hot topic for us a few times over. So for someone who's boarded in sleep and obesity, I'd like to take a deep dive with that today.
Yep. Hey, Maramus, I love to read, some of the content that he will regularly post on LinkedIn where, he kind of gives his take on a certain new type of therapy or, maybe just a trend that he's seeing in the sleep medicine industry. So excited to hear what he has to say. We met him last year at Seattle's influencer event, and it was that was great to meet him there, and we had talked about getting him on the podcast. So it's been a little bit, but we were able to pull it off. So happy to have him on the show today.
You guys ready to get started?
Let's do it.
On to the show.
Lights out.
Soulish is redefining how sleep apnea risk is identified. Using a simple selfie-style face scan, our AI delivers a sleep risk score in under a minute. The Soulish platform then connects providers to evaluation, testing, and therapy through one seamless pathway, because every patient deserves expert guidance wherever they are. Choose Soulish. One selfie, better sleep. Scan the QR code to know more.
SleepTech Talk is brought to you by Fisher & Paykel. Fisher & Paykel Healthcare is a leader in CPAP mask design and innovation for over 20 years. Their unique technologies have benefited millions of OSA patients through their top CPAP masks. These advancements continue to further enhance patient experience and outcomes.
Welcome, everyone, once again to another episode of SleepTech Talk, the sleep podcast with your hosts and friends, Emerson Kerr, Robert Miller, and me, Dr. Gerald George Moneycroat. Folks, thank you so much, so much for all the love, the share, the likes, and the subscriptions that you have been providing us over all these years, and it's because of you we keep going. And so be sure to give yourselves a pat on the back because we sure do that for you, virtually, of course. But a huge shout out to our sponsors, without whom we can't keep doing this. Be sure to check them out. We thank them so much for the love and support that they've provided us to help us keep going and make us be able to do these things and provide really good content for each and every one of you. And once again, we have a fabulous show. And to tell you a little bit more about it, Emerson.
Thanks, Jerry. We have Dr. Mohammed Usama with us today. Dr. Usama is triple boarded, and among the things he's triple boarded in is obesity and sleep medicine. He comes from the Seattle area. It's got an interesting history we want to ask him about. But Dr. Usama, welcome to the show. We are thrilled to have you with us today. One of the questions that we love to ask our guests is, how did you get here? And how did you get into sleep medicine? So we know a little bit from our conversation earlier, but can you share with our audience your journey from into sleep and how you ended up in Seattle and what are you doing now?
Yeah, absolutely. Thank you so much for having me. So I'm working in Greater Seattle area as a sleep and obesity physician, and happy to be here. So first, to answer your first question, how did I get into sleep? I got into sleep accidentally, honestly. I did not plan to be a sleep doctor, but during my residency training, I took an elective in sleep medicine, and that made me realize that how much impact sleep has on metabolism, your health, your energy, your performance, all of that. And then, if we treat and address sleep disorder, first, the outcome is very quick as opposed to other chronic medical problem. You can see a day and night difference. So there is that gratitude. And also, a lot of medical problems they get improved, which we are not expecting, and that's what brought me to took that elective in the first place, because a lot of my patients, I was sending them to the sleep clinic, and their high blood pressure was getting better, their depression and mood was improving, their sugars were improving, and I was like, what magic is going on there? So I took it. And the other reason is that I like technology, and I feel like sleep is a perfect mixture of mind and body medicine as well as technology. So there's a lot of technology in it. So that's what brought me into sleep. But I think that was the best decision I ever made. I did my internal medicine training at Wayne State University in Detroit, Michigan, and sleep medicine training at Cleveland Clinic. And after that, I've been practicing for quite a while now. And for the past 1.5 years, I've been in Seattle area and enjoying it over here.
So you said that you love the mix of technology and medicine. I think SleepTech Talk is the right place to be right now, right? So,
Absolutely.
so what took you to Seattle, though?
Well, I did most of my training in Midwest, and then I stayed in rural Wisconsin for a while. So my wife, she's a psychiatrist, and she was doing her psychiatry residency over there. But I think it was just incredibly cold, and I, you know, I don't have any issue with winters or snow, but my wife absolutely hates snow. So over here in Seattle area, the weather is much milder and much better. The winters, it doesn't snow over here. If it does, it did once this year, and next day the rain washed it over. So it's much better, and from climate wise, and I like to hike a lot. I like a lot of outdoor stuff. So I feel like Seattle is the only big metropolitan city in the United States which has 3 national parks within 1 to 1.5 hour drive distance from it. So I just love it over here. Yeah.
Doc, reading just your story, you're boarded in obesity and sleep medicine, clearly giving you some really keen insights into how those overlap. What have you seen, especially over the last few years as we see more about GLP-1s? Where do you see that intersection, with your specialties coming together? How do those complement each other and really allow you to have a keen insight into those special patients?
Yeah, that's a very interesting question. So actually, as a sleep disorder, so the major sleep disorder we treat in the sleep clinic, which is the most common we see in the sleep clinic, is obstructive sleep apnea. And one of the big underlying risk factor is obesity or weight gain. It's not the only risk factor, but it is one of the major underlying risk factor. And I was always trying to address the underlying obesity in my patients who had sleep apnea. So I sent them to our weight loss clinic, and a lot of the patients, they wanted the care under one roof. And a lot of them did not want to go. A lot of them were lost to follow up, and I felt like I was not in control. And then, my interest became in obesity kind of developed when I saw the results of GLP-1 therapy in obstructive sleep apnea. And at that time, I decided that I'm going to treat these patients with GLP-1 therapy, and that is going to address their weight as well. So might as well get some additional training and board certified in obesity medicine. So that's how I drew into obesity medicine. But at the same time, I feel like obesity is not like it's on the diagnosis list. It's not like a side conversation if you're talking about obstructive sleep apnea. So you cannot ignore the role of underlying obesity if someone has obstructive sleep apnea. That is my journey into obesity medicine.
So with that being said, the big conversation, or the big conversation that you hear all the time is, get rid of the obesity, your OSA is gone. And now with this miracle drugs that are out there, first injectables, and now we have the oral tablets for GLP-1 drugs. People think it's like a magic bullet. I pop these pills, I don't need to worry about OSA anymore. So what's the actual truth? What's the myth behind these two things? I think that's a big thing floating out there. Wouldn't you agree?
I would totally agree. Because, whenever a new therapy comes out, we try to pitch it against the established therapy, but that should not be the case. But let's talk about first the role of obesity in obstructive sleep apnea. So we know that weight gain, it worsens obstructive sleep apnea. And if you lose weight, it improves obstructive sleep apnea. So Peppard and colleagues, they did a study in which they showed that if you gain 10% body weight, your sleep apnea gets worsened by 32%. But if you lose the same 10% body weight, your sleep apnea only improves by 26%. So it's easier to grow into sleep apnea than to grow out of sleep apnea. So, because once the disease is established, there are some changes that occur at pharyngeal level, at your cellular level, that makes it difficult to get rid of obstructive sleep apnea. So weight loss is not the only picture, because obstructive sleep apnea is not one disease. So, and I'll come to that. So the big underlying pathophysiology for obstructive sleep apnea, it is airway narrowing, which could be due to obesity, which could be due to extra fat in tongue or cheek or in your pharynx. But at the same time, so that is one part. But at the same time, obstructive sleep apnea could also be due to small mandible or lower jaw. Obstructive sleep apnea could also be impacted by your arousal threshold, your ventilatory instability. It can be impacted by your muscle responsiveness. So all of these things, interplay. So obstructive sleep apnea is not one monogenic disease. There are multiple pathways to it. So losing weight, it always helps. But at the same time, we have a lot of data from meta-analysis in bariatric surgery cohort that showed us that people who underwent bariatric surgery lost a lot of weight, and their sleep apnea got improved, but majority of them, they did not get rid of obstructive sleep apnea. Even the minute amount of patients who got rid of obstructive sleep apnea, there are some studies which have shown that after bariatric surgery, if they attained a healthy weight and got rid of obstructive sleep apnea, if we serially followed them in next 3 to 4 years with them maintaining the weight, the obstructive sleep apnea came back. Okay, despite them maintaining the weight, because again, it's not just due to the underlying obesity is not the only factor. It worsens with age, right? And I explained you there are other things, other pathophysiologic mechanism which can causes it. So that was a reason, because not everyone responds same way to the weight loss. And then the weight loss, it's a chronic process. Losing weight, I say that it's the easy part, but it's the maintaining weight or chronic, long-term weight management, that is really an art. So that was the reason why American Academy of Sleep Medicine, in their latest guideline for treatment of obstructive sleep apnea, they did not say that bariatric surgery is a treatment option for obstructive sleep apnea, which a lot of bariatric surgeons, they tell my patient that I will do this bariatric surgery, you will lose your weight, and I will cure your obstructive sleep apnea. So they are probably wrong in saying that. So that is why American Academy of Sleep Medicine said that weight loss should be addressed in all of the patients who have obstructive sleep apnea, but it's an adjunctive treatment option. It's not the primary treatment option. So these patients still need to be some sort of primary therapy, whether that is CPAP or oral appliance or mandibular advancement device or hypoglossal nerve stimulator. So yeah, it's not, the answer is more nuanced than that.
A sound sleep calls for a high-performing mask. Introducing F&P Nova Nasal with swing fit headgear. From fitting and seal to minimal noise and draft, it's performance defined. Go to fphcare.com/Nova Nasal to learn more.
Treating my sleep apnea has renewed my appetite for life. What matters to me now is giving my family a little treat.
Soulish is redefining how sleep apnea risk is identified. Using a simple selfie-style face scan, our AI delivers a sleep risk score in under a minute. The Soulish platform then connects providers to evaluation, testing, and therapy through one seamless pathway, because every patient deserves expert guidance wherever they are. Choose Soulish. One selfie, better sleep. Scan the QR code to know more.
So Jerry's going to eye roll when I bring this up. He's already smiling, knowing what I'm going to say. But you mentioned the endotypes. And, when we begin to talk about those, I think it's such an important subject because I bring it up a lot on this show. But how does that factor as you look into the future and the ability to see those from sleep studies emerges? How do you feel like that's going to influence your decisions in therapy and in ongoing care for your patients?
So I think we should take some lesson from heart failure management. So if someone has heart failure, they're not on a single therapy. It's not like, one drug to rule them all. They're on beta blocker, they are on ACE or ARB therapy, they are on aldosterone antagonist. And so they're on different form of therapies which are hitting different pathways, right? So similar is the case with obstructive sleep apnea. It's not one machine to cure it all, or one pill to win it all, or one injection will cure it all. The future is gonna be a lot like heart failure, because these therapies, they work in conjunction. Maybe it's going to be PAP therapy plus GLP-1 therapy. Maybe in some patients it's going to be mandibular advancement device plus positional therapy. Maybe in some patients it's going to be hypoglossal nerve stimulator plus GLP-1 therapy. Or maybe down the road, we know there is a pill coming for obstructive sleep apnea as well. It's going to be that in combination with oral appliance. So, it's going to be in conjunction, because first of all, it's good to have multiple therapies with different pathways, because if a patient is not tolerating one therapy, they have more option to stick to. At the end of the day, our goal is to treat the patient, and regardless of how effective the therapy is, CPAP is more than 99% efficacious. But if someone is not using it, then the efficacy does not matter. It's about reducing the mean disease burden, how many nights they're using it, how regularly they're using, how many hours they're using it. And if something else reduces the mean disease burden, then that's good, and that's the way we should go towards. So again, the answer is more nuanced, and we need to have more holistic care, while treating the patients, and kind of take it as just like as I said for heart failure. We have so many therapies, so similar will be the I think future with obstructive sleep apnea treatment and management.
So I do read your content on LinkedIn a good bit. I know that you've got this Substack blog that you also write articles and put content out. You seem to be a student of the industry, because I feel like I'm sort of in a similar position where I love all of the new diagnostic tools, but I don't want to just know about them. I want to know how they work. I want to know the nuances and the differences to understand the capabilities and what is good science, what's not so good science. And then also with the different therapy options that are out there, I do love the fact that you're thinking about things from a phenotyping standpoint. And we certainly need that broader approach to sleep therapy. So tell us a little bit about your just desire to know about all things sleep.
So I think, personally, I think that, we provide medical care to patients in sort of a very epileptic way and very archaic or Jurassic way. So I'm always trying to come up with ways which, are sort of disruptive or out of the box solutions. So because, 80% of patients who have obstructive sleep apnea, they're not diagnosed. And there are probably 1 billion people on planet Earth who have obstructive sleep apnea. So that's a big disease burden. So we need to, in order to really diagnose these patients, we need to come up with novel, new, innovative pathways. Just like we cannot solve the problem of traffic congestion by building more highways, similarly, we cannot solve the epidemic of obstructive sleep apnea by building more sleep labs. Home sleep study is here to stay, and we need to come up with some innovative or novel pathways to meet the patients where we are. So, interesting thing is, when I was in Wisconsin, I was working in a rural community hospital, and in that hospital, I designed a program of inpatient sleep apnea screening and screening, diagnosis, and management. So what happened was that, and this was the first rural hospital in the United States in which that kind of program was implemented. We know big academic centers which have such programs, such as West Virginia University, Cleveland Clinic, where I trained at, and University of Pennsylvania, and some other more academic programs. So just to give you a brief overview, that every patient who got admitted to that hospital in the ER, they got a stop bank score, and when they got admitted, and if their stop bank score was 3 or higher, it sent an alert to the admitting team in the inpatient side that this patient is at high risk of obstructive sleep apnea. So a sleep medicine consultation is recommended. And then they consulted me. I went inpatient in the hospital and did a complete sleep evaluation while they were admitted. And then right before their discharge, we did a portable sleep study while they're in the hospital, because we wanted them to be more physiologic to near their point of discharge. And they left the hospital with a CPAP machine. And a lot of so the concept was just like the concept of everyone who get admitted into the hospital during the flu season, they got a influenza shot before they get discharged. So the point of contact the patient has with the healthcare system, we need to do the most in that. And also with that novel inpatient sleep apnea screening and diagnosis program, when we tracked the data down the road, we saw that those patients, they were more compliant to therapy because they came to the hospital usually with a health scare like a heart attack or heart failure or COPD exacerbation. And when their cardiologist told them that you need to use your machine and we need to treat this sleep apnea, otherwise your atrial fibrillation will keep coming back. Your heart health is not going to be good. You will have increased readmission due to heart failure. They listened and they were more motivated. And so we need to come up with innovative pathways like this. So it was that discovery. And then I just, that is why I'm very interested in new developments, so I can implement them somehow into my practice and see how it can help my patients.
Well, Doc, we are really getting really close to time. And first off, I think it's really awesome to hear your interest, your depth of interest in the field, and it's really cool that you implemented such things. And I just took down some notes. I thought it was really, really cool how you compared the treatment there of obstructive sleep apnea, moving in the direction of just like we have with congestive heart failure, how we're moving in that direction now, where there are different options. Also understanding that you can't just simply open more sleep labs to do this. This is just like trying to alleviate congestion in the roads just by adding more roads. It's not going to help you. So we really appreciate the insight, but we are close to time. Where can people get more information? You have a Substack. Could you give us a shout out what your Substack is, and so that people can look at it?
Yeah, so people can find me on LinkedIn with the handle Sleep Warrior MD, on Twitter, on LinkedIn, on Instagram. I'm most active on LinkedIn, so that is the best place if you want to reach out to me. And but in addition to that, I have my Substack as well, which we can include in the show notes. It's sleepphysician.substack.com.
Got it. And you heard it here, folks. Sleepphysician.substack.com. We'll make sure to have that in the show notes. So, Doc, thank you so much for joining us.
Thank you. Thank you for having me.
And thank you all once again for joining us. It's been a pleasure. Thank you so much for the love, for the likes, the shares, the subscriptions. And until next time, we say, lights on.
Be sure to check out our clinical sponsor, Sleep Review Magazine. More details in show notes.
All right, that was another show, and that was quite a bit. What did you guys think?
Jerry, I think it's fascinating to hear someone talk about just all that goes into thinking about the GLP-1, the sleep patient. I mean, there's so many moving parts, and for someone like that to really take that deep dive was so interesting today. And I really appreciate Dr. Usama's perspective on the complexities of these types of patients.
I agree. I mean, GLP-1s are still being talked about this day and age, and well, this day and age, I mean, at this time. And it's interesting, especially because when the pill came out in January, it became hot once again. So it's good to hear his take on it and alleviating some of the myths.
Yeah, I think that one of the things that I loved hearing from him today is just his more holistic approach and to treating patients who have issues with sleep apnea, for instance. Where maybe it's a combo therapy, or the idea that a GLP-1 is the magic bullet that may treat sleep apnea by itself. So, love his take on that, and the phenotyping models that he talked about. That's always sort of a funny topic, I think, for us, but just love his perspective. And I think in a world where there seems to be some form of practice where it's just diagnostic study CPAP, diagnostic study CPAP, diagnostic study CPAP, that having these trendsetters who are willing to sort of think outside the box and treat patients a little more comprehensively is certainly great for the field.
And I love the fact that he said we now have options for patients. That's probably the biggest thing out there.
Absolutely.
Right. Well, I think this is a great place to stop. Folks out there, thank you all so much. Until next time, cheers.